Here in the United States, we rank dead last in infant mortality of Western countries. We are last. We have more babies dying in problems than any country in the world, despite all this sophistication, all these methods that are recommended.
The medicalized birth system sees every pregnancy as a potential disaster, and therefore they often interfere in things that don't need interfering, and their interference leads to more problems.
They create a lot of the disasters. Women are getting cut unnecessarily. They're getting C-sections unnecessarily. I believe it's just more convenient for doctors and the hospital, and they make more money from insurance.
They start augmenting with Pitocin, and then you don't like the Pitocin, so you get an epidural. Then eventually the baby doesn't like labor very much, and they do a C-section, and they pat themselves on the back for a job well done, and it was all iatrogenic. Getting pregnant, growing a baby, going into labor and having a baby is not medicine. It's not medical.
Moms watching this want the do's and don'ts. Where are the real risks? We want to hit all of that because we're going to talk about the myths. Care about the health of children? Oh, you're going to want to watch this episode. Of course you're children. Or do you have somebody you know that's about to have a baby, thinking about to have a baby, just had a baby? This episode, we're going to answer a lot of questions. We're going to bust into a lot of birthing myths like breech, C-sections. Did you know 1/3 of births in this country are C-sections? That's a problem. And you're going to find out why that's a problem. And we're going to talk about some answers because you probably know a lot of people, maybe yourself, that was C-section. I'll bring some light to that. But my next guest is an expert on all of these topics about birth. Oh, we're going to even top into some vaccine talk too, because everything babies, everything birth, this is the show. All your questions are going to answer. A lot of you are going to be sharing this show. My guest right here. Oh, and of course, my beautiful wife is here because she knows more about this topic than me because we had all our babies at home. By the way, you'll hear that story. All right, Dr. Stuart Fischbein, thank you for being here. Tell them a little bit about your experience because you've won massive awards. You have.
I have.
And you're an OBGYN. And wait a minute, you're saying home births are safe and you can do these things, but you educate on this. You educate the doctors, you educate the public, and you even do some consulting with pregnant moms that are concerned or scared.
That's true.
That's my intro.
It's been a while since I won an award, type of award. The kind of awards that I value are things like being the Doulas Association of Southern California's Physician of the Year, not necessarily getting something, an award from the American College of OBGYN.
That's not happening.
Yeah.
Well, that's not happening.
Not going to happen.
But I don't seek that kind of acknowledgement. My satisfaction comes from the fact that I've evolved to a place now where I'm free to speak freely and I'm free to teach the skills that make my profession, or formerly my profession, obstetrics, unique.
Yeah.
And that would be like breech and twin skills.
Right.
And what to do in situations where where the medical model turns immediately to the scalpel.
Yeah.
They immediately go, oh, that's too dangerous. I want to talk a little bit today, if we can, about the definition of high risk, all those sorts of things. But my journey began like anybody else. I went to medical school. Well, not like anybody else, but I went to medical school. And you have to make a decision in your third year of medical school, which you're totally unprepared to make. And that is, what you're doing is you're doing clinical rotations, and you have to choose which residency you want to apply for. You don't know anything at that point in your life. You're enthusiastic, but you're very naive. And you have to choose, am I going to do internal medicine? Am I going to do surgery? Am I going to do radiology? Am I going to do OBGYN? How do you know? And you make that decision. And once you get into that sort of that hamster wheel of training, it's very hard to make changes because you're financially in debt. You have put in a lot of hours and a lot of work. But during my third and fourth years of medical school, really enjoyed my obstetrical rotation. And I liked it for many reasons, but one of them was that it was what's called longitudinal care. You may know about that because you take care of people over their lifetime. There's only 3 specialties in medicine that really do that, and that is family practice, internal medicine, and OBGYN. I liked surgery. And I certainly like catching babies. And the other 2 are dealing with usually chronic diseases, hypertension, diabetes, lupus, things like that.
But here's what I'm shocked about already, because you like surgery and catching babies. I would think that you would be still an OBGYN because 1/3 of births or C-section, hey, you got your surgery and you're still delivering a child.
Maybe that's why doctors are so quick to easily do that because, but for me, I just like the idea that I got to do all those things and yet I still got to catch babies, which was the sort of happy, and I'm going to use this term very carefully. I would call it happy medicine then. I want to be very careful right now because getting pregnant, growing a baby, going into labor and having a baby is not medicine. It's not medical.
No, it's not. Well, but by the way, that's part of the problem, I believe, because they treat it like a disease or a sickness, right? Instead of like the way the rest of the, well, I can't say the rest of the world, but I would say that
the rest of the world is, a lot of places are a lot worse.
Yeah.
But the American College of OBGYN has a statement in one of their guidelines that says pregnancy itself is a high-risk condition. And if that's the prism by which obstetricians are being trained, then you can see that they think that, that nature's design is flawed. Now, I would argue that nature's design is perfect, and it occasionally goes wrong. But the medicalized birth system sees every pregnancy as a potential disaster, and therefore they often interfere in things that don't need interfering, and their interference leads to more problems.
I was just going to say that. Well, they create a lot of the disasters. We're going to talk about that because we're going to say, I want the do's, moms watching this, future moms watching this, want the do's and don'ts. Where are the real risks, right? We want to hit all of that because, and we're going to talk about the myths because, women are getting cut unnecessarily. They're getting C-sections unnecessarily. I believe it's just more convenient for doctors and the hospital, and they make more money from insurance. So I believe there's a reason it's 1/3, but I don't believe it's what they're telling them why they have to do it. What about epidurals? And what about all these other things that you know about? What about
every one of these
shots?
topics I could spend an hour talking about.
What about vitamin K shots? What about vaccines and hepatitis B?
So when I was pregnant first time and my husband wanted me to stay home, and of course my response was, you're not having the baby, I am. I'll go to a birthing center. I'll feel better being monitored, right? However, I wasn't going to do a sonogram. I refused. I knew that I would only wait until I could hear the baby's heartbeat with a stethoscope before I would, because I'm not aborting. So what's it going to tell me? Could it potentially give me fear? Could it potentially disrupt the baby, forming inside of me? So that wasn't an option. So someone recommended to me that I read a book by, believe her name was Susanna Arms.
Sure.
Called Immaculate Deception. It was written in the 70s. Well, I read that book and it didn't take long before I realized, okay, it's the same process now that it was then. What's changed?
Oh, it's worse.
But for women, it's the same. What's changed is the fear they've instilled, the monitoring that they've begun to do, the potential risks, honestly, that I believe in most cases they've created. So I decided I'm staying home. And I had the good fortune of his partner had a few home births after a few hospital births. And I stayed home, and I can tell you the things that I personally experienced. Not that it's easy, but I was never afraid when I was home. I knew I was going to have a normal birth based on my prenatal care. I knew she came to me. I think it cost us $200 to have the baby at home.
Is that it?
I believe it was serious. And that included the prenatal care. Now, granted, that was, 27 years ago.
I feel badly about that.
But I know, you want to write her a check?
Yeah, I think we should.
I actually think we have along the way because she has been just a source of support over the years for a variety of reasons. But what I really felt so confident about was I just never, when it was time to go into labor, a woman's body hormonally takes over. It made so much sense to me, and it frightened me that if I disrupted that process, that could potentially put me into their space. And if I just stayed in that nesting mode, let my hormones do what they wanted to do and what they were designed to do, I would be content. And you know what? Every time I had a baby, that was the outcome. And I even delivered, my second one was posterior.
Well, something about your history and growing up in life made you think that way, because made you sort of immune to the fear-based or the fear porn that's put out there about pregnancy. So it gives credit to you that you were able to withstand that. Okay. So
and reading and educating myself.
Right. And the question is, why don't more people do that? And I want to get to natural birth and I want to get to the high risk, but there's a thing that we talk about all the time in our world. It's called the wedding analogy. I don't know if either of you have heard the
I have
wedding
not.
analogy. Okay, good. All right. So when there's two events in a woman's life that are probably the two most important in a traditional woman's life, and that is her wedding day and the birth of her children. That's not to belittle the possibility, the thing that you got a law degree or you won a gold medal, or those are big things. But when you're older, those are the two things that are probably going to matter more than anything else. And for your wedding, you plan everything. You pick the venue, you pick the invitations, you pick the color of the napkins, you pick the steak or the chicken, or you pick the people. You invite people that you like.
Yep.
You do everything. You spend a lot of money on it and you put a lot of time into it.
Mm-hmm.
For your pregnancy, you have a Blue Cross card or a Medicaid card or whatever, and you say, okay, I'm going to go to this guy because this guy's been doing my pap smear for a decade and he's an OBGYN, so I'm going to go to him. And you don't put any effort into it at all. And then you end up getting what you paid for, and you don't get the experience that you wanted to.
Right.
So the analogy is, what if there was something called wedding insurance? And what if you paid every year when you were 20 years old you paid it to an insurance policy, and when you got married, your wedding was covered, but you didn't get to pick the venue. And you only got to eat the fish. You didn't get the chance to have the steak. And invited people to your wedding you didn't like, and you couldn't wear the dress that you wanted. Who's going to do that?
No one.
No one.
It'd be devastating.
Right? But that's what we do for our pregnancy. So one of the things we talk about is treat pregnancy not as a medical condition. Don't treat pregnancy as something your insurance should cover. If it does, great, but don't rely on that. Put money aside. Get a health savings
Absolutely.
account. Invest in it. Check things out. Go to your first prenatal visit, or actually even before you're pregnant. Go see your local obstetrician or your local midwife and sit down with them for half an hour, and see if they even give you that much time. But sit down with them and ask them questions as if you're interviewing them to paint your house or to buy a car. You don't necessarily aren't going to do that. You're the consumer. We go in there with this power differential that they're the doctor and we're the patient, and whatever the doctor says I'm going to do.
You might have one of 5 doctors too, right?
That's a
problem.
And the system has changed so much for the poor that even if you like your doctor, that doctor may not be the one that's on call when you go into labor, or when you call at night with an issue, you're going to get a stranger. And we don't take care of strangers the same way we take care of people we know.
Fact.
That's just human nature.
Yep.
So let me back up for a second and talk. These topics I could really, I know I got to abbreviate myself.
Me too. I can see open loops everywhere.
I got to abbreviate myself.
Yeah.
Let's just talk about how mammals give birth. We've got, I don't know if these are boys or girls. Right?
One of each. This is a girl.
Boy.
Okay. Has she had puppies or no?
That's a whole story. We'll talk about that later.
All right. But anyway, everybody knows what it's like when a mammal gets pregnant. All right. When a mammal goes into labor, where do they go?
They nest.
They go off someplace
somewhere
private. And who goes with them?
No one.
Nobody. And if they're hungry, they do this amazing thing. They eat.
Yeah.
And if they're thirsty, they drink. Okay. And when they're uncomfortable, they move. They get up, they roll, they pace, they lie down, they do the things that they need to do because they're responding to the senses that their body is experiencing. And when they're ready to give birth, they lie down in the dirt or in the straw or in the closet or under the bed, and the puppies come out. Nobody rushes in to cut the cord. Nobody takes the puppies away from the mom. It's not sterile. And if in labor, there's little kids running around the house, what do you tell the kids?
Be quiet.
Yeah, go outside. Leave the dog alone. Same thing in nature. If an animal in nature is laboring and there's a predator that's approaching, or there's a forest fire, or there's a thunderstorm, they're going to stop laboring. They're going to put out the right hormones that stop the contractions and get up and go. And only when they feel safe will they go back into labor. This way, nature ensures the best chance of survival. It's in all of us. So everything I just described for your dog that's natural, in the medicalized birth model, we do the opposite.
Yep.
We take a woman from her home, we have her get in a car, drive someplace unfriendly, someplace scary, that we ask them a bunch of questions that don't mean anything.
Cold.
We have them put on a hospital gown, which signifies that you're a patient. We put you in a bed. By the way, you had home births or?
All of them.
Yeah. How much time in a home birth when you were laboring did you actually just lay in bed?
0.
Right. See, I don't even know the answer, and I know the answer. Okay. Because I spent, by the way, my background is such that I didn't even get to that, but I spent 28 years working in a hospital system. And then a little over 12 years, I left the hospital, for reasons we can get into later if we want to.
Yeah, because I can't believe you went from that.
Yeah, I'm curious about that.
And I did home birthing, and then I started doing breeches and twins at home, and diabetics at home and hypertensives at home, much to the chagrin of the medical community. Sure. But we'll get to that too. Anyway, so that's how mammals give birth, and the system that we have has forgotten that. They start an IV, they draw blood on you, they're interrupting you, there's lights on. Your husband may or may not be allowed to be in there. Certainly the people that you want at your birth, they say, well, we have a limit of 1 in the room or 2 in the room, but I want my mom and my sister there. Nope, I'm sorry, you can't have. Why? Because they have policies, and they make policies into these things that I want people listening know, and you've heard this probably and other people from your podcast, that policies aren't laws. Right. Hospitals can have a policy. You say, I understand it's your policy, but I'm having my mother and my sister are both going to be in the room along with my husband. And they say, no, you can't do that. And I said, yes, we're going to do that.
Quite honestly.
And if you knew that ahead of time,
you wouldn't have been there.
Then you wouldn't go to that hospital.
That scares
that's why
me.
you've got to check these things out before you're pregnant. That's why you go to that first visit with your doctor and you do the interviewing.
Yep.
Don't let them take your blood pressure. Don't let them draw blood on you. Don't sign any documents. Go in there and just have a conversation. What happens if I go past my due date? What happens if I'm in labor and you're not on call? What happens if I break my bag of waters and I'm not contracting yet? What happens if my baby's breech? Do you do breech delivery? Oh, no? Why not? Ask very politely. Ask the question. We're not going to change the system from above. We're going to change the system. The women are going to change the system only when they start demanding things.
Mm-hmm.
Yeah.
That's why the education here is very important. Yes. Because most people would say if it's breech, posterior, C-section. I mean, that's just what they're going to say.
And meanwhile, my first baby was posterior. My midwife knew. She told me to lay on my left side. 4 hours later, I delivered. The second one, we didn't know he was posterior, and I actually delivered him posterior. And I had no sensation to push, and of course, she told me to push. But if I had had an epidural or something like that, I would have. You'd
have been a C-section.
It would have been right. Absolutely.
Well, we know that all those interventions increase the cesarean section rate.
Yep.
And we know that, yes, when you can move, your body will respond. When the baby is coming down a little, what's called asynclitic, it's a little sideways instead of coming straight down. A woman who's not numb can tell you that. And that's, you watch a woman in labor, sometimes she'll pick up one of her legs and she'll put it on the bed or put it on the step. She'll move, she'll rock. That's why you have a doula or a midwife present who understands these things, who can put you on your side or certain positions. There's some weird positions with weird names that they do for babies that are occiput posterior, which is what you're describing. For things like breech and twins. I'll get to that in a second because with your permission, I want to spend a little time talking about high risk.
Yeah, please define it.
Because all these things are labeled high risk. From anything from being over 35 to being too short to having a high BMI to being hypothyroid, all these things. Everything they can find, they'll label you high risk. There's rarely a woman that makes it through her pregnancy in the obstetric model of care that isn't labeled with something that's high risk. I'll tell you an interesting side story.
Age.
So, by the way, being labeled high risk, what now happens? Because I have no idea.
First of all, you put the woman on alert. So now the woman is more fearful.
She's scared. Mm-hmm.
Correct. And so you're changing the chemistry of that as that baby develops inside that mom. That mom's worrying. But let me tell you an interesting story. What happened to me, because I thought that I'm I've become this nice traditional hybrid of a midwife and an OB. And every time a woman came into my office for a new consult, I would take their history. And when you take a history, you probably know this, you ask about their chief complaint, then you ask about that. Then you ask about their past medical history, their past surgical history, their meds, their allergies, review of systems, family history. That's how we take a history. When I got to past medical history, a woman would come in with me, she's pregnant. When I got to past medical history, automatically out of my mouth would roll this sentence. Do you have any other medical problems?
Other. You
caught it. For 30 some years, I was saying that. Finally, a woman looks at me and she goes, what's the first one? And I realized that even, that obstetrician in me was still considering
this is a problem.
Her pregnancy to be a problem. It's not a problem unless it becomes one. That is sort of what midwives have taught me. And the reason that you asked why I changed from being a hospital doctor to a home birth doctor was...
Very few people make that cross. I don't know any.
It's very hard to let go of the security and the technology and the sort of the mass formation that I have to have this here. And I don't want to ostracize myself from my friends and my colleagues. So they do that, and they don't really care about the fact that their outcomes suck. But the reason I did it is because I first early in practice was a not very busy obstetrician. It was a different era then. You didn't come out of residency in 1986 and get a job working a shift for some employer. You came out, you hung up your shingle, so to speak, and you just built your practice from scratch. And one of the things I did besides cover free clinics and back up doctors when they were on vacation or assist them in surgery or cover emergency rooms was I was asked by some local midwives if I would take their home birth transports. And I said, sure. But I didn't say sure because I thought home birth was a good idea. I didn't know anything about home birth midwifery. I said, sure, because every time I got a transport, I could bill for that and I could make money. So I did it more as a mercenary than I did it as somebody who thought it was a good idea.
Yeah.
But that changed me forever because I began to spend time talking to the midwives and I began to learn a lot of ways of doing things that I had never thought of. And they would question some of the things that I was doing, like, why am I having this woman push in lithotomy position, which is that position where they're on their back with their legs in stirrups.
Mm-hmm.
That's ridiculous.
And why am I washing off her bottom with betadine? And why am I covering her legs with these sterile blue drapes? Why am I turning birth into a sterile procedure? Mm-hmm. Why am I dressed in a full hazmat suit with one of those funny boofy hats on and wearing a mask to catch a baby? Well, I'm doing that because the infectious disease people at the hospital tell you have to do that.
Yeah.
But it doesn't make any sense because we don't do that at home.
No,
and if your dog was having puppies and you were standing by, you wouldn't be dressed in a full hazmat suit. And then why am I cutting the cord immediately? Why am I showing this beautiful thing that you just created to you, Marilee? And then I'm walking it across the room and setting it down in the warmer. So the nurses can do all kinds of stuff to this baby that don't need to be done.
It actually breaks my heart. Like, it actually makes me feel emotional that women don't get to have the experience that I had. And it's not easy, but it is not to be feared. It is not. It is beautiful, and you're safe. And I was outside within 30 minutes on the porch swing with my baby.
Women are amazing.
Well, it's funny because our neighbor who's a nurse was like, oh.
And she's one of those, by the way.
Yeah, she's one of those. Like, I didn't know you had when did you have the baby? I'm like, just now. I mean, like, we just
I was downstairs outside, was like, right?
Like, almost like she didn't know what to do. Like, well, how can that be, right? Yeah, we just had the baby.
I like watching like British dramas, like some of the old ones. Mm-hmm. Currently, I'm on Poldark season 5. Okay,
haven't heard of that.
Yeah, it takes place in Cornwall in the 1790s.
Oh wow!
And the women, they had their babies, and the next day they're making bread and they're outside chopping the wheat and doing this
babies
stuff.
Right here.
Yeah, no, I'm just kidding. But so anyway, that's sort of how it goes. But high risk is what my colleagues are trained and bathed in during their training programs, and this is a problem with how they're trained. Because obstetricians, prior to 1977, there was no such thing as a high-risk specialty, something called maternal fetal medicine. The Society for Maternal Fetal Medicine was created in 1977. In 1970s, the C-section rate in the United States was 5%. Now, I know that correlation and causation aren't, we all know that argument, but let's just follow me for a second. It was 5%. Now it's about 35%. It's about a 700% increase. The induction rate in the 70s was almost nil. Now over 30% of women are induced.
They want to be too, ironically enough.
Well, they're convinced that they think crazy. They need to do that. In 1970, a woman maybe had 1 woman in 3 maybe had 1 ultrasound. Now there isn't. Probably 95% of women have at least 3 or 4 ultrasounds. Mm-hmm. Some of them with high intensity color flow Doppler, 3D technology, 4D technology, all that stuff. Completely, most of the time as a screening tool, completely useless.
Yep.
We have continuous fetal monitoring. We have labor curves. We have 80% of primips, first-time moms, getting epidurals in the United States. All those things have been done. And the outcomes, which really matter, which if you look in any paper on obstetrics, the outcomes that they look at are fetal mortality, fetal morbidity. Mm-hmm. And that's translated into cerebral palsy, brain damage, and intrapartum death or stillbirth. Right. The outcomes haven't gotten any better.
Well, hold on. What people don't know that always blows me away is that here in the United States, we rank dead last in infant mortality, meaning we have more
of Western countries. That's correct.
Of Western countries. We are last. We have more babies dying in problems than any country in the world, despite all this sophistication, all these methods that are recommended. So
and
what's
what
wrong?
They'll argue, it's a typical argument. They'll say, yeah, but that baby that last week, that baby we picked up with the problem with its blood flow, and we picked it up and we did an emergency C-section. We saved that baby. Yeah, you are going to save some babies with all this technology, but what are you doing to all the other women
and
that are having this unnecessary testing?
What did you do to create that problem in the first place that you became the hero?
Theoretically, that's true, right? Yeah. Right. But I'm just saying that overall, the outcomes aren't getting better. And if you're, Einstein said it best, if you do something over and over again, expect a different result. Insanity. It's the definition of insanity. The same people that have created this whole system for us, that are now the high-risk specialists, that are the ones that are training future obstetricians to, or basically be feeders to the high-risk specialists. Because when I was training, I start to sound like my dad. He hiked uphill both ways to school, 12 miles through the snow barefoot. That was my dad's. Right. My dad used to tell that story. Yeah. Yep. So, but when I was a resident, if somebody had diabetes, I took care of that. I was trained to do that. If somebody was hypertensive, as an OB, I took care of that. Then now, no obstetrician does any of those things. All they do is refer them off to a specialist. Mm-hmm. This one, that one, that one. And so women are being shopped all over the place, and they're going to people that are called high-risk specialists. And that's freaky, because suddenly every woman thinks that they're high risk because their doctor told them they're high risk.
Yeah. Right.
But high risk doesn't mean what people think it means. And if I asked 10 people, what does a high risk mean? I would get 10 vague, non-specific answers.
Well, I would think most people would say, well, it means I have a greater chance of having a problem at birth with my baby.
What does greater chance mean?
Yeah, right. Greater chance. I don't know.
Right.
Yeah.
But that's the problem.
It's scary.
So that's what high risk means. High risk is something that makes the medical system uncomfortable. If we remember that, because they will treat all diabetics the same. It doesn't matter if you're well controlled or poorly controlled, you're labeled a diabetic and you follow the algorithm for diabetes. Mm-hmm. Same thing for breech, same thing for twins, whatever type of twins you have. They treat them all the same. And to overtest generates more revenue. By the way, every time you create a diagnosis of high risk, somebody's making money off of that.
Yeah, another specialist gets brought in.
And all the incentives are backwards. We pay more for ultrasounds than we pay for not doing an ultrasound. We pay more for a vaginal C-section than we pay for a vaginal delivery. It's the law of economics. If you supplement something or subsidize something, you're going to get more of it. Mm-hmm. So what's the incentive for a doctor to take on something that may take him more time, perceived to carry more liability for the same pay, yet in a hospital that makes more money from a C-section, their responsibility is to keep the hospital afloat. So people think they go to the hospital and the hospital is going to care about me.
Yeah.
Hospitals don't care about you.
First of all, C-section, if I'm a doctor, I'm going, all right, great. So the birth is at Monday at 2:00. I control my schedule. Unlike if it's natural, I'm at the pool with my kids and I got to go because, Junior is coming, right? It's like, you got to go. That's not very convenient.
And that's part of the reason that they've changed. The doctors are now basically working in a large group. They work a shift. Much better lifestyle.
For the doctor.
But for the doctor, yes. No, it's a better lifestyle for the doctor. However, what's the job satisfaction like? Because for me, and maybe I'm different, I don't think so, I like to see the culmination of my work. And if I'm taking care of somebody for 7 months and she goes into labor and someone else catches the baby, I would find that unsatisfying. The mindset of young doctors that are going into medical school and residency now is such that that's the kind of people that they want in medical school. They don't want shepherds. They want sheep. Because the sheep are easier to control.
That's what's frightening.
And they have a system already set up for the sheep.
How do you break that system? Because everything is set up and we have a snowball effect going on. Because women, there aren't many people having these conversations. There aren't, I know that I remember, I think something that is important for women to know, and what I had read in that book was that if there is potentially a threat and it is life and death, you really have, it doesn't matter where you are. Is that true?
No. Well, I'm
you
not
mean
sure.
at home versus...
yeah, if you were, but if there's a risk, you have about an hour and a half window to transport.
It depends. No, that's too vague.
Okay.
I would just say that if you have a true emergency, you're better off obviously being in the hospital.
Sure.
But there's a couple things about that. You're far more likely to have a true emergency because you're in the hospital, because of the way you're being managed.
Sure.
Your labor is being intervened upon. You're numb, you're starved, you're immobilized, you're interrupted. You've got all these things going on. You're hyperstimulated. So that's a big problem when you think that if I have an emergency, I'm going to be in the hospital. So it's better to be in the hospital. The other thing about being in the hospital is that everybody has this false sense, well, if I have an emergency, there's an operating room 30 feet down the hall. But they're not sitting there waiting for you.
Right. That's right.
It may take them anywhere from, in a really, really good hospital, 10 to 12 minutes. Most hospitals, 25, 30 minutes to get. If you really have that placental abruption or that fetal bradycardia, that cord prolapse, where the baby's really in trouble, it's not going to matter where you are.
Right. And I think that's the point that's made in the book too. And if you live close enough to a hospital, if you've had good prenatal care, oh, by the way, I correct myself. Ellen was $1,200. I think I paid her like $200 a month.
Thank God.
So I was thinking about that. I was like, that doesn't.
I was like, okay. I'm like, wow.
I'm sure the price is higher. She is now retired. I think Simon was her 400th birth, my last one. But I know
That's
he was.
So cool.
Yeah, super cool. But in any event, it's a trained midwife knows the signs, knows the prenatal care that you're receiving, how your body's responding to the pregnancy itself at large. And if you feel, you just feel good when you're about to have a baby.
For those people that think that pregnancy is a high risk condition, it really isn't when you don't meddle with it. When something isn't going well, a trained doula or a trained midwife is going to recognize. And the analogy that I often use for that is because midwives are experts in normal birthing. So when something isn't normal, kind of like there's Peter tingle.
Totally.
Peter tingle goes off. Their spidey sense goes off.
Yep.
And what I mean by that is if you live in the same apartment or the same house for 10 years and you go out to dinner, and you come home and open the front door, and the chair in the front hall has moved 3 inches from where it's always been. You know something is wrong. Was there an earthquake? Did the dog hit it, or has someone been in my house? You may not know what's wrong, but you know that something is wrong. It's the same thing. And since midwives are experts in normal birthing, and since most women are normal, the medical model would not have you believe that, then most women should be cared for by traditional midwifery type care. The problem, of course, is that medicine is now trying to take over midwifery and even licensed midwives and doulas and regulate them so that they become basically mini-me's, mini OBs.
There were hospitals Ellen didn't want to transport to if needed, right? She would prefer to be living closer to a different hospital than another hospital because some doctors were like, they frowned upon the fact that this woman was going to have a home birth. And I think that in and of itself is the first problem, is allowing the midwife to be respected for the authority that she's gained. Like you said, oftentimes it's just wisdom and intuition through her experiences.
They're professionals.
Through her experiences, which are vast.
My obstetrical profession feels like they're a lesser subset of them, and that's wrong. Mm-hmm. They also feel that nature is flawed.
Yeah, and that major premise is wrong.
The whole underlying premise is wrong.
That's right.
If it was right, then we'd see it in outcomes. We'd see better outcomes. Yeah. In all the things that they're doing.
We're last in infant mortality. We have the worst statistics.
And despite a 7-fold increase in cesarean sections. Continuous fetal monitoring, which is where you wear those belts in labor. There was an article just last week in the New York Times. Finally, it's like, welcome to the party, pal. They finally put an article out that says, they called it the worst test in medicine. I don't know if it's the worst test in medicine, but they're finally pointing out the fact that over 50 years of use, not has only been no evidence of benefit from having these belts on, but there's evidence of non-benefit, and yet it's pretty much standard in almost all obstetrical units in the United States.
During labor?
During labor.
Wow.
I mean, I know back
Why do they do that?
We were doing research, even the ultrasound done at the wrong time when DNA was doing certain things can create problems.
Correct.
Yeah. So as innocent as they make the ultrasound, oh, let's just do another ultrasound. If you hit that on the wrong day of certain cell division, you just mess some things up.
You know, I heard you talking to Dell on one of your recent podcasts about the fact that there's never been any research, randomized double-blinded controlled studies on any of the vaccines and that whole thing. And we've known that. Those of us in our community have known that for a long time. And finally, people are waking up. It's the same thing here. Ultrasound use is universal. It's a form of non-ionizing radiation. The last studies that I've done a lot of looking into this that I can find, it came out of China in the late 80s, when the machines were far less powerful than they are now. Nobody's looking. But everybody knows that maybe we shouldn't carry our phone next to our belly, and maybe we should turn off Alexa, and maybe we shouldn't really buy a house next to a 5G tower. We all know that, yet doctors are continually telling women that there's no risk to scanning. That's, again,
nonsense.
They should say, we don't know of any risk to scanning because we haven't looked yet.
Yeah,
right.
Exactly.
That's what they should say.
That's right.
It's different than saying there's no risk.
I interviewed Sherry Tenpenny, and you know what she said? She said something that Casey, the congressional meeting when we watched Bobby go through all that, right? The one Casey said, wait a minute, there's 3 studies done, double-blind placebo studies done on 3 different vaccines, and complete lie.
Yeah.
So you know what the study, so they were saying that they're lying. That's not true. Well, actually, she pointed out that the studies were literally the placebo group, they were giving straight aluminum instead of water.
Yeah.
So it was comparing the vaccine to aluminum injections. Oh my gosh, that's a double-blind placebo trial. That's not how that works.
Yeah,
But of course, they were like, oh no, so it actually performed the same symptoms. Of course.
Senator Casey, that's who we're talking about.
Yeah,
right?
Senator Casey made this point.
He has the same, I would call it the same syndrome that most of my medical colleagues have, is they were trained in medical school. They have a cognitive dissonance to believe that anything that they were taught could possibly be wrong. It would be very hard for them to face after 20 or 30 years of doing something that I've been causing harm. Yeah. So there's this whole idea that not only do we have to state what we're doing is true, but anybody who says otherwise, we have to crush them. Yeah. And this is how this is one of the coping mechanisms for cognitive dissonance, where you have 2 very uncomfortable thoughts. Can you imagine? I mean, for me, I had to go through this because when I came out of residency, I was cutting cords immediately. I was walking babies over to the warmer. I was encouraging vitamin K shots, hepatitis vaccine. I was doing all the things now that I tend to mock because it's all I knew. But then then somehow most of my colleagues, their education ended at that day. And they just do what they're told because out of habit or policy, and they don't want to challenge it. They don't want to look into it. Doesn't matter that their outcomes are getting worse. They don't look at that either. If I do a C-section on a woman for a breech baby, am I doing good? Can we talk about this for a little bit?
Yeah,
sure.
Okay. Yeah.
So.
Yeah. I mean, by the way, I want to get to everything. Like you've thrown out a lot of things. People are going, what's wrong with an epidural? What's wrong with?
Oh, we'll get to that too.
Yeah. So I mean, you mentioned a lot of things that people are going.
Will go off.
Wait a minute. Episiotomy. What's wrong with that? What's wrong with this?
By the way, just briefly, I had 1 stitch with my first baby because my midwife worked very hard, and the perineum opened up and did what it's designed to do. I had no stitches, and Daniel came out with his hand like this on his face. I had no stitches with any other baby. I mean, nothing.
You will find that the chance of needing stitches, by the way, can I ask, what position were you in when you delivered? Do you remember?
Do you remember?
You were in a lot of different positions. I think you were on your back, actually, because that's what you found most comfortable.
Yeah, some women,
the end,
you're more likely to tear when you're on your back, which is the standard position that women are in the hospital most of the time. And if we see less tears when women are on all fours. I've seen kind of worse tears sometimes when they're on a birth stool where they're pushing straight down.
I remember being like during labor on the edge of my bed with like my upper body on the bed and kneeling, right? Kneeling and just like comforting myself that way. But at the very end, I think we have video of this stuff.
We just watched a video, and I think, all my kids decided not to have kids.
It's not unusual, but again, and you had a stitch. It may or may not have been necessary. Years ago, we used to stitch everything. Now we're finding that unless it involves muscle and stuff like that, you really don't have to.
Yeah, I probably didn't need it. But it was superficial.
That's on a specific birth. I can't
but still,
really.
I was impressed.
Can't really comment.
I was happy with that one first baby, and of course, he expanded me more than probably needed because his hand was on his face.
Daniel figures.
So he's always expanding me more than needed.
Story of his life. Head anyway,
I don't even know where I'm going to go with this conversation.
Let's get back on track, guys. You were about to make a really important point.
Yeah, I want to make a really important point. Okay. The best guidelines, and again, remember, guidelines are simply guidelines. It's kind of like the Pirates of the Caribbean. It's the code, and it's not really a code. It's more like guidelines, actually. Guidelines are not something that necessarily has to be. But when ACOG or ARCOG, the Royal College of OB-GYN, put out guidelines, institutions, administrative people, risk management lawyers tend to use those guidelines and make them benchmarks for quality, and they change policies in the hospital when they're not necessarily supposed to, because a lot of the guidelines, even 2/3 of the guidelines, are not based on good science. They're based on what's called level C evidence. But putting that aside—
What's level C evidence? Define that.
Consensus opinion.
Okay.
It's based on opinion.
Lowest level.
Irrelevance.
Yeah,
okay.
Top science is essentially randomized controlled trials.
Okay.
Level B science is going to be things like meta-analysis, chart reviews, looking back at things, not randomized controlled trials. And level C is that there's not very much evidence out there, but the consensus opinion thinks this. Now, if you put a bunch of maternal fetal medicine doctors in a room, they're all going to come out with the same consensus. They don't invite midwives or people like me into the rooms when ACOG comes out with a consensus. But the best guidelines for breech are the Royal College Guidelines of OB-GYN. They came out in 2017. And why they're the best is because they talk about the risks of breech birth, but they also talk about the risks of cesarean. Whereas the American College Guidelines don't talk about the risks of cesarean, which if you're going to counsel someone about breech birth, you're going to recommend cesarean, you should at least give them the information about cesarean. But what they say is, and again, because it gets down to fetal mortality or stillbirth, the rate of stillbirth with a vaginal breech birth in their study, properly selected, skilled practitioner, is about 2 per 1,000, 1 in 500.
Okay.
How about 1 per 1,000?
What's that?
You said 2 per 1,000?
2 per 1,000.
Okay, so you could say 1 for 500. Never mind.
No, that's the same thing.
Yeah, that's my point. Yeah.
Yeah,
I just like to bring it down.
Yeah.
My brain works better that way.
Okay, good.
Yeah. You're like, it's the same thing.
Sometimes sometimes my brain gets ahead of me and I say things and I need to be corrected.
Yeah.
So,
well, the reason they said 1,000 is because they probably looked at 1,000 anyway.
Well, and by the way, anytime you have a number that comes out that perfectly, you know that it's rounded because numbers don't come out that perfectly. For cesarean for breech, it's 1 fetal death in 2,000. So in other words, it's 4 times higher the risk of having a neonatal death if you have a vaginal breech birth than if you have a cesarean. That's where the sort of the guidelines come from. Well, what's 4 times riskier, that means that's a lot. Well, not only before I go to the difference between 1 in 500 and 1 in 2,000, I want to talk about what's the risk of a baby dying with a head down vaginal delivery. And that, according to the Royal College, is 1 in 1,000. So it's 1 in 1,000 versus 2 in 1,000. For 2 in 1,000, everyone's suggesting you section all breeches. For 1 in 1,000, no one's suggesting you section all head down babies.
Right.
So the risk of it not happening, and this is where it gets confused, it's not confusing, to clarify, if you have a vaginal breech birth, you have a 99.8% chance of not having a stillbirth.
So if you have a vaginal breech birth.
A
breech birth, yeah, that's the point.
99.8% is 1 in 500. 99.8% chance. If you have a vaginal head down birth, it's 99.9%. If I asked you, Marilee, what's the difference between 99.8 and 99.9?
Not much. Not enough to be worried about.
For that, all obstetricians being trained are told to section all breeches.
Wow.
With no concern, however, if that woman, and never asking the question, does that woman want a second baby? Because if she wants a second baby, then you've now put her and all her future babies at greater risk because of the risk of uterine rupture, the risk of placental implantation problems, often called placenta accreta, that can occur after you have scarred uteruses. You put all her future babies at greater risk. Is that part of the counseling of a doctor who says to a woman, your baby's breech, you have to have a C-section? Does he ever ask her, oh, by the way, do you want more babies? No, they don't ask the question because they don't care.
No, they're just dealing
all they want to deal is get that one baby out expediently, like you said, 2 o'clock in the afternoon, be out by 3:15, or whatever.
Yeah.
They can get that back to the office, get home for dinner, whatever. That's what they want. Now, this sounds very callous. It's not meant to impugn the individual physician who, again, is essentially a cog in the wheel. But it's a wheel of their own making, and it's time for those physicians, as you said, to step out of that wheel and say, this isn't right. What we're doing isn't right. And I'm an obstetrician, and about 1 out of every 20 pregnant women who walk into my office is going to have a breech baby. I'm an expert in all things obstetrics, and I don't know how to take care of her. So I'm only going to offer her a C-section. And not only am I only going to offer her a C-section, I'm going to impugn the possibility of a vaginal delivery. Instead of telling her that vaginal breech birth properly selected is a reasonable choice in skilled hands, I don't happen to have skilled hands, but there's a doctor across town or a midwife over there who knows how to do breech. Why don't you go have a consult with them? That would be ethical.
Yes.
That's not what's happening.
Right.
Because they are projecting their anxiety about breech, something that they should know about, onto the woman and skewing their counseling to funnel the woman down the path toward C-section as being safer. But I just told you how safe it is. They're not recommending that all head-down moms have a C-section. Yet that's 1 in 1,000. So for 2 in 1,000, it's too high. For 1 in 1,000, it's not too high. They're not thinking like this. There are so many things, guys, that my colleagues, I want to mention 2 others.
Sure.
Because I'm on this not thinking clearly roll. Have you ever heard of something called the labor curve? Okay. Labor curve is women are supposed to dilate at a certain rate if you're a first-time mom, and there's a different curve for a second-time mom. It's named after a guy named Friedman. In the 1950s, he was doing this research, and he was doing vaginal exams on women every hour or 2 hours, which of course, in and of itself, is an intervention and has all kinds of problems. They didn't think so in that time because they don't think out of their box. And he would chart labor curves. How fast is a woman dilating from like 4 centimeters to completely dilated? And they would make this curve. And if you remember basic geometry, in order to draw a curve, you need a bunch of scatter points. You got people that go slow, you got people that go fast, you got people that go in the middle. And the curve is the median. Correct. So how did they use this curve? That's the median of a bunch of women's labor curves. Well, they said that if you're not dilating on this curve, you're going too slow, which means we have to rupture your membranes, or we want to start Pitocin because you're dilating too slow. But if you think of the basic geometry, how many women are below that curve? 50%.
Yeah, exactly.
So what they've decided, they made a curve that's the norm, and 50% of women are automatically now moving too slowly. Why didn't anybody think of that? Why is that something that has been used for almost 70 years?
That's crazy.
And they still use it in many institutions, still use the labor curve.
And so then they start drugging at that point.
Yeah, they start augmenting with Pitocin, and then you don't like the Pitocin, so you get an epidural. And you've heard of the term, the cascade of interventions. That's what happens. And eventually the baby doesn't like labor very much, and they say your baby's not tolerating labor, and they do a C-section, and they pat themselves on the back for a job well done because they got a crying baby in the bassinet.
That's how it happens.
And it was all iatrogenic.
And it was all because of the stupid curve, because 50% of the babies.
Because who decided to put labor on a time?
Wow. Yeah, that's crazy.
Michel Odent is a very famous surgeon who, he wasn't really an obstetrician, but he just passed away this past year, and he touched all of us in our field. And he made the analogy that babies are ready like apples on an apple tree. They don't all they all fall off at the same time. They all fall off at exactly the same day. No, they don't. No, they don't. And babies are the same way. And we've decided, by the way, 40 weeks is the average. Yeah. Some people say that first-time moms go longer than that, but technically, I have found that actually my average is right on 40 weeks. But that's the middle of a very flat bell-shaped curve.
50% are under, and 42
are over.
Right.
Yeah.
Right. But when you go beyond 40 weeks, your doctor will label you overdue.
Yeah.
But you're not overdue.
Right. I tell women that all the time. I'm like, the baby comes when it's ready.
Now, if you go beyond a certain point, is it wrong to do surveillance on the baby?
No,
not necessarily.
Right.
for reassurance. Everybody feels better about knowing their baby's fine. But if the surveillance is fine, there's no magic number about 41 weeks or 42 weeks or 40 weeks and 1 minute. You know, there isn't magic about that. Right. Yet in the medical model, they do that. And one other thing that is really stupid, and this is something because I've done a deep dive into twins. I did a paper that came out last year on home birth of twins. We had 100 sets of twins in my care, and me and my colleague Rick Safries published a paper on this. They do a lot of ultrasounds on twins. Okay. Certain types of twins need more surveillance than other types of twins. I'm not going to get into the details of that. People can look me up if they want to find out more information, or they can find this paper. Maybe you have show notes. We can put it in the show notes if you have that.
Yep.
But one of the things that they do is that they do a lot of ultrasounds on twins. And it's done by maternal fetal medicine specialists, again, these high risk, supposedly specialists. And they measure babies, and then they plot them out on a curve. Who plots them out on the curve? The computer does that. The ultrasound machine has a built-in system. They put the numbers in, and it makes this beautiful printout. Twins, for the most part, grow about the same rate as singletons to about 26 weeks. Term is 40 weeks. So for the next 14 weeks, twins tend to grow a little bit slower. We all know that because everybody, if you ask any OB, is a term twin generally smaller than a term singleton? They're going to say, yeah. Mm-hmm. Okay. So why are you charting their growth on a singleton growth chart?
Wow.
Yeah.
Because from 26 weeks on, a baby that's twin is going to look like it's falling off the growth, and it's going to then be labeled as potentially small for gestational age or growth restricted. And because it's growth restricted, they're going to do
that. Yeah.
Most twins do that. Mm-hmm. Correct. And we end up with over 50% of twins, if you follow them on a singleton growth chart, are going to be labeled growth restricted. Does anybody believe that 50% of twins are growth restricted? No, but it generates a lot of revenue, generates a lot of business for the maternal fetal medicine doctors, and then they intervene upon them and they get the twins out earlier than they should probably come out.
So it ends up in a C-section.
Or earlier, and the babies end up going where? To the newborn intensive care unit.
Or they induce labor.
Right. They induce labor. They artificially change.
Yeah, they always have a due date, right? Don't they? Twins usually do have a due date, like when they've scheduled it.
Well, twins usually come earlier. If you leave them alone, as we did in my paper. Now, of course, my numbers of 100 are not big enough to reach statistical significance. Guys like Peter McCullough would say that, nope, that's not significant, but it is an observational study. And when we left women alone, our average gestational age for twins was 39 weeks and 0 days. Now, if you look at the standard teaching for twins, if you have something called monodi or identical twins, they tell doctors they should be out by 36 to 37 weeks. And if you have non-identical twins, by 38 weeks. And that is standard teaching. And every obstetrician thinks that way. And they automatically put all twins into that category. But labeling all twins into a group and not individualizing your care is foolish, but it is the model by which doctors practice. And they have to stop that. And midwives have taught me about individualizing your care. You may have two people that are diabetic, and one of them is poorly controlled.
Yeah.
And that one needs more surveillance and maybe needs to be delivered early. The other one is doing fine, and her blood sugars are probably better than yours and mine because she's wearing a pump. I mean, diabetes today is not the same disease as it was 30 years ago. People are wearing continuous glucose monitoring. They have insulin pumps. They can look at their phone. They know what their blood sugar is. They're in really tight control. You know, I wore a glucose monitor for a couple of weeks as I was experimenting. I drank a Mexican Coke, which I really like. And my blood sugar would go up to like 1hamdride.
Yeah.
Oh my gosh.
Right.
What's a
That's
Mexican
the beautiful
Coke?
part about being able to see
it's made with
real sugar.
cane sugar as opposed to fructose. Yeah. So
we brought
anyway, I got off topic.
Yeah,
I just want to say it's how stupid it is.
Yeah, these things are really dumb.
That they're using a singleton growth chart for twins.
But we're making these procedures because of these stupid decisions like a growth chart, timing.
Yeah, and if our outcomes were getting better, then you could say, well, it's a stupid decision, but it's working.
Yeah, right.
But it's not working.
It's worse, right? We have more infant mortality than any civilized country in the world. That's a problem. Okay, but you brought up a lot of things that people want to know about, like what is the problem with inducing, right? You said a lot of statistics there, but when we talk to women all the time, and these are women who are concerned about their health, they're told to just induce, and they're not worried about that. And they're told to take painkillers, Pitocin.
Epidurals. You mean.
Epidurals.
Yep.
I'm sorry.
And even Tylenol during pregnancy. We didn't take anything. There was nothing.
You're stating there's a problem. Let's tell them what these are.
Okay.
What it is.
So there are times where induction, epidural, cesarean section are very valuable. So let's not pretend that I'm beating up on all of them. The problem is clearly they're way overused. And what they don't take into account is the intelligence of nature's design. Why did nature design things the way it is? We've evolved to a point where we conceive, we grow a baby. Well, I don't. You do. Women grow babies, they go into labor, and they deliver the baby without any of us thinking about it. It is nature's design.
Yeah.
Sometimes things go wrong, and that's where we need interventions.
Absolutely.
And maybe 10% of the time that is. And that's a made up number too. I don't know. It could be 5%, could be 15%, doesn't matter. It's a small percentage of pregnant women that really need that medical intervention. But there is advantages to nature's design, because during the process of conception and baby growing inside, there are things happening in there that we don't even understand.
Sure.
There are hormones that are passing back and forth between mom. There's electromagnetic energy passing back and forth, things that we can't measure that are going on between mom. There are cells being transferred. There are stem cells being given. They're back and forth, these sort of things.
Stress.
Babies helping mom.
Stress.
Yeah. And
Emotional
so
stress.
when a woman is happy, she's secreting dopamine, she's secreting oxytocin, your love hormone. Those things are crossing over. The baby's getting a sense of warmth and well-being. When a woman is stressed, she's secreting cortisol, she's secreting adrenaline, she's shutting off her endorphins and her dopamine.
Yep.
And
And the
the baby's
baby knows
getting a
it.
sense of
Fear, problem.
anxiety, fear. Now, babies, again, this is all theoretical because I don't know how you study this, but it just makes common sense. And by the way, I've found that science either proves what common sense would tell you or the science is wrong. Just kind of a basic tenet.
True.
Right. So the baby is neurons are developing during this period of time. Its little cells in its heart are developing. Its little cells all over its body. Its liver is developing. Skin is developing. And there's genes that turn on and turn off. I'm not an expert in epigenetics, but I know that sometimes things are expressed differently.
Absolutely.
And so what are the cues that are doing that? Well, mom and baby have been designed over eons to do this together. And when you meddle with Mother Nature, there will always be downstream consequences.
So taking where
they could be small, they could be large.
Absolutely. We so many women say, I want the epidural because I don't want to feel pain. It sounds so logical. Oh yeah, why deal with pain if you don't have to? But again, the natural way is pain is normal, but if you take it away, there's consequences to that.
You don't feel the urge to push, correct? If you
that's true too. But let's start with a basic question, because I've written about this too.
Mm-hmm.
I wrote a blog when blogs were things. I wrote a blog once called "Labor is Not a Toothache," because if you're going to have your teeth drilled, nobody really wants to do that without Novocaine.
Yeah.
Okay, but babies are not the same thing.
Mm-hmm.
So let's talk about a basic question: is why is labor painful? Because women's uteruses contract during pregnancy. They're called Braxton Hicks. Those aren't painful. You had them.
Mm-hmm.
They're not painful. Why is labor painful? Now, some people could look at the biblical reason, and I'm not here to debate, eating the fruit from
God
the
did
forbidden
say it
tree.
would be painful.
Yeah. So there's that. Okay. Put that aside. Let's take physiologically why it's painful. And maybe it's painful because there's a reason it's helping the baby and the mother work together. Because when you have a painful stimuli, your body puts out certain chemicals. It puts out adrenaline.
Mm-hmm.
What does adrenaline do to contractions? It spaces them out.
Mm-hmm.
No, it spaces them out. Like when a mammal is approached by a predator, puts out adrenaline, stops contracting, so it
slows it,
so it can fly or get away. I don't mean fly. Well, there are mammals that fly. Bats fly, but all right.
Fight or flight.
When you put out other hormones like besides adrenaline, you're going to put out cortisol when you're in pain. You're going to put out endorphins. Endorphins are what? Your body's opiates. Helps you deal with pain.
Okay.
Mm-hmm.
And you're putting out oxytocin which is what your body's using to make yourself contract. And that also is different than synthetic Pitocin in our country, which, makes your uterus contract, but it doesn't do the other things that oxytocin does, which is like make you feel warm, make you feel loved, make you feel connected, cause milk letdown, those sorts of things. So when you use Pitocin, you interfere with body's natural oxytocin. But back to the epidural thing. So when you're having that contraction, you're uncomfortable. You put out those hormones, some of those hormones, and I have colleagues of mine who debate this with me, but I believe that some of those hormones certainly cross the placenta. And the baby gets a waft of mom's endorphins, a waft of mom's oxytocin, her adrenaline, and all those things. Because what's happening inside the uterus is something that's brand new to that baby. That baby's been living in there for 9 months, happy as a clam, and suddenly it's starting to get squeezed a little bit. And when the uterus contracts, blood flow through the placenta is diminished. So the exchange rate between oxygen and glucose and things is lessened for that period of time, sometimes shut off completely. Now, babies are designed to tolerate that for 30, 40, 50 seconds, whatever a contraction is. So, but something's changing. And it's causing the baby probably to feel stressed. But here comes a waft of mom's oxytocin and mom's endorphins. And basically, I know that this sounds very corny, but it's like, oh, mom's here. I'm okay. I'm fine. And then the water breaks. And now the baby's really getting squeezed. And even the cord might be getting squeezed. And the baby's like going, what the F is going on? Babies don't swear, but I'm just projecting. All right. And the baby's getting a waft of mom's hormones. But now mom decides, I think I'll have an epidural because I'm really uncomfortable. So mom gets an epidural. And suddenly she has no pain anymore. So her communication through the hormonal milieu has disappeared. Yet you're still contracting. And as a matter of fact, because the epidural might slow your contractions a little bit, they'll probably add Pitocin. So now your contractions are getting really strong and your baby is not connected to you anymore. And if you've heard me in some other podcasts, I've said this before. The baby now is trying to cope with this without mom. And what happens? We're doing this stupid thing with the continuous belts on. And now we're starting to see the baby's heart rate rise. Or we're starting to see some changes we don't like in the pattern of the heart rate. And we go, your baby's not tolerating labor. Let's turn off the Pitocin. And then your baby seems to be okay for a while, but now you're not dilating. So they got to turn it back on again. And the baby isn't liking it much. And so they say, listen, you're only 6 centimeters. You're not going to make it. We need to do a C-section now. Is there a problem with getting an epidural? Yeah, you have to understand that anytime you mess with Mother Nature, there is an interference. Now, there are pros and cons, and each woman needs to decide for themselves, having been given full, true, and honest information, what they want to do. The problem with our medicalized birth system now is they give skewed information.
Yep. And you know what? Once the baby comes out, it's over. Like, it's over. Your pain is done. And
well, not always.
Well, I mean, under normal circumstances, right? For a normal
But you're now secreting oxytocin beyond belief.
Yes. And
for milk and just you're smelling your baby and your baby's on your skin.
But not wanting to feel the pain, honestly, it's just selfishness. It really is. Because we have been so conditioned by the fear.
If they know the truth. If they know this, then it becomes selfish.
Point.
But when you don't know, why would it be selfish?
That's why we're having a conversation.
And also, if the fact that we label it pain, we could label it something else.
Absolutely.
And in the midwifery world, we use the word surge, something like that, because it really is, it is uncomfortable.
It's uncomfortable.
And the other thing that makes you want an epidural more is the way the hospital treats a woman in labor, which means that you have to be in bed and be monitored. The rest of us, when we're in pain, what do? And the example I often use is if you bump your elbow.
Ouch.
You say, well, that ouch is a kind 4-letter word. You often say a different 4-letter word, but then you rub your elbow. The answer, why do you rub your elbow? You rub your elbow because it feels better. So the answer to the question is, why does it feel better? And the reason it feels better is simple neurology. If you bang your elbow here on the opposite side of your brain, there's a little area on your brain that's going ouch, 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 right where you hit it. The minute you start rubbing your elbow, or if you burn your finger and you run it under cold water, blow on it, you start to stimulate the nerves around the burn. And your brain can no longer pick out the specific spot.
It's a distraction.
So if you watch a woman in labor at home who's free to move about the cabin, right, she's not going to sit there when she's having a contraction and do nothing. She's going to move. She's going to stretch. She's going to want to get in the water. She's going to want somebody to rub her back or squeeze her hips or do something.
Or feed her.
Or yes, do any of those things to distract her for the 30 or 40 or 50 seconds that she's having that discomfort. And then she gets a 2 or 3 or 4 minute reprieve. And then she does it, and the receptors regenerate and nature does its thing, and it does it all over again. When you start to interfere with that, you end up with this cascade of interventions, which is great. All of this is part of that rise in cesarean rate, the rise in induction rate, the rise in NICU admission rate. By the way, the rate of NICU admission, newborn intensive care unit admission, in the last 20 years has gone from a little over 5% to just under 10%. Now, are you telling me that 10% of babies in the United States need to go to the NICU? So there's only nefarious reasons for that. One is we're not doing well.
Right.
Or two, women are just sicker, which I hate that explanation. You know, it's kind of like the idea that, well, you know, the C-section rate's rising because women are fatter or women are older. No, that's not why that's happening. So the answer is, another nefarious one is that they make more money by putting babies in the NICU. So hospitals are developing policies to shift more babies to the NICU, which is nefarious as can possibly be.
Either way, nefarious. Either way, it's nefarious.
It's not a good reflection on the system, right? Right.
Yeah. Look, I think when we look at this, you've talked a lot about C-sections. It seems like everything that they're doing leads to more C-sections, which explains the 1/3, of births end in C-section. But we haven't talked about the problem with C-sections. I could talk a lot about that. Now, what we know now, we didn't even know this. Back 20 years ago, when I was, really dealing with a lot of women making this decision, we didn't know about the microbiome like we do now. We didn't know that a woman not brought through the birth canal, their baby doesn't pick up her microbiome, and it sets them up for more gut problems and immune problems, right? We didn't know any of that. What we knew as chiropractors is that when we would see necks in children with immune problems, we would see these straight necks. And we'd be like, well, where did that happen? Are you trauma, no trauma, no trauma? And C-section babies, because it's like a boot stuck in the mud. They pull the baby from the head. Yep. God forbid they use forceps, right? But so it traumatizes the neck, which most people don't understand this, but that traumatizes the nerve system and sets up the baby for many different problems, immune problems, obviously structural problems, and a life of pain later.
Yeah. Well, I talked to another chiropractor at one point, and he said that the baby's head on the mom's perineum is like the first baby's adjustment of the baby's head. And the thing about the C-section,
subluxation.
And the C-section also, we had somebody on our podcast who talked about innate fetal reflexes and the importance of integrating fetal reflexes the baby has to navigate the things the baby has to do to come out through the vagina, the rotations and the flexion and the extension and all those things, prepare the baby to integrate those reflexes into its future reflexes. We all test babies when they come out. Oh, do they have the Moro reflex? Do they have the plantar reflex? Do they have the walking reflex? Yeah, they have all those things. But when you take a baby and you don't let it go through what nature designed it to go through, I keep saying that. I keep coming back to this theme. There are going to be consequences downstream. Absolutely. The microbiome is a huge one. We know, and we've known for decades that babies born by C-section, again, not big numbers, but certainly statistically significant, higher odds ratios of things like asthma and autoimmune disorders in children. And we know that we have chronically ill, the chronic illnesses in our children are rising. And I know that there's lots of different factors that could be involved with that. But I have to tell you, there's no question to me that our immune system begins in the womb, even begins before conception, which is why preconception for parents and getting themselves healthy and detoxing for 3-6 months before they even try to conceive.
That's what we do. That's what I teach.
Yeah.
And not detoxing when you're pregnant. Of course, you don't want to do that.
Well, you want to be in the best situation, and you don't want to toxify when you're pregnant, which of course my organization, ACOG, is still out there right now pushing. At 28 weeks, they're pushing the flu, Tdap, and COVID vaccine.
That's insane.
And they're still doing it. And at 34 weeks, they want you to have the RSV vaccine to protect your baby.
From
those potential diseases that the baby can get before the baby, because the baby can't get its own protection from vaccines until it's 6 months old. So we have to do that.
It's like a puppy. Take your puppy outside.
I would have to tell you that they are insane. The head of ACOG, Stephen Fischbein is his name right now. He's the president of ACOG, keeps putting out memes on their Instagram account, talking about how they still recommend the COVID vaccine for pregnant women in any trimester, by the way. And by the way, it is safe to give the COVID vaccine, flu vaccine, and DTaP vaccine all at the same time.
Oh my gosh.
Okay, because there's a lot of science behind that. Not
Zero.
Right. So they do these things. And again, I don't know that they can look themselves or they see themselves as we see them. They have no credibility. And once you lose trust like that, why are we allowing them to then dictate to midwives and potentially doulas and how they're supposed to practice? Back when the banks failed in 2008 and 2009, you guys remember that. We're all the same age. We remember that because of the mortgage crisis and the fact that they forced banks to lend money to people that couldn't afford to pay them back, and they bundled them all and they did all that stuff. And the banks crashed. And people in charge of the banking committee in Congress were basically Chris Dodd and Barney Frank.
Yeah, I remember.
Then the shit hits the fan and it all collapses, and Congress now has to step in and fix it. They fix the problem that they caused, which is kind of like what obstetricians are doing. They're causing problems and then fixing them. But who do they put in charge of fixing the problem? Chris Dodd and Barney Frank.
Same
two guys.
Yeah, gosh.
So my point being with MAHA and everything that's going on, and if Bobby Kennedy's listening or if anybody has connections to him, please, when you're working on correcting what's going on in the maternity situation, don't make the mistake of going to ACOG and asking for their opinion.
Right.
They're the ones that got us in this mess in the first place.
Absolutely.
Yep.
And don't go to the American College of Nurse Midwives, and don't go to the Society of Maternal Fetal Medicine Doctors. They're all in on this, I would call it the scam that's making them a lot of money, giving them a lot of power, but is not improving outcomes for the mothers and babies of our country.
And just for the record, there is a big difference between a nurse midwife and a lay midwife. And I had a lay midwife.
Yes, and even a lay midwife is not a term we like to use anymore. We basically call them like unlicensed midwives or whatever else. And many midwives who've been licensed are choosing to drop their license because the license becomes so restrictive. In my old state of California, they used to have a thing for like physician supervision. Midwives had to be supervised by physicians, which is the dumbest thing. Again,
ever.
Proves that they don't understand what midwifery is.
Yep.
And it was a power thing by the the California Medical Association and ACOG to control the midwifery. They were able to trade that and get rid of that physician supervision, but they basically sold their soul for that because they gave up women in labor before 37 weeks, after 42 weeks, they gave up breeches, they gave up twins. Prior to 2014, midwives in California could do breeches and twins if they had somebody that said it was okay, which was somebody like me, and I would say it was okay, and then they would do them. After 2014, they were no longer needed physician approval, but now they couldn't do them anymore. So be very careful, anybody listening out there, if you're lobbying your state to license midwives or license doulas. License doesn't mean better quality. License means you're becoming subservient to the state. Right. You're giving up your sovereignty and your autonomy because most of the dumbest things in medicine that have ever been done have been done by licensed people who are board certified, who are fellows of the American College of OBGYN or members of the American College of Nurse Midwives. And they are the ones that have led us to the point where we are right now, that you are having me on your podcast to talk about the fact that our maternity care system, as you said, is leading to the worst results in Western world.
I want to get to the other pitfalls that women are told, and it's happening to lead to we have the most baby deaths in the world in civilized country. You have the shirt on there. It's what is it? Reteach Breech, right? So that's a passion of yours.
Yeah,
but we've never said, you've alluded to the fact that a breech doesn't have to end in a C-section. So you feel strongly that it can be a normal birth. What's different about that? And what do you teach, and why is that your passion?
Well, when I was training back in the early 80s, I was a resident at Cedars-Sinai Medical Center in Los Angeles, and we had an affiliation with LA County USC Women's Hospital, which in the early 80s was the busiest hospital in the United States. They were doing about 22,000 births a year there, which is 65 babies a day.
Wow.
And I was there every other day for 4 months. So you got 60 days, you can do the math, you figure it out. And again, if breech is 3 to 4% of term pregnancies, I'm seeing 2 or 3 breeches every day. And if twins were about, 1 in every 40 pregnancies at that time, or 1 in every 50 pregnancies, now it's about 1 in every 30, 1 in every 32 pregnancies. I'm seeing 1 or 2 sets of twins every day. So we just learned that it was a normal function, a normal thing to take care of breech babies. And matter of fact, we loved them because it made us feel like obstetricians, because we could actually do something. And we did too much hands-on stuff. You know, when a breech was beginning to protrude, we would grab it and twist it and turn it out and pull it out and sweep the arms and get it out, because that's what we were trained to do. But breech was just a normal thing for us. And then for whatever reason, there were articles in the late 80s and early 90s that started to debate the question, is C-section safer for breech? And the question was probably there because a lot of people were doing breech who didn't know what they were doing. Mm-hmm. And when you don't know what you're doing, yeah, you can get in trouble. You can get, a brachial plexus injury or a neck injury or worse. So there was no standard when they studied these things. They didn't have standards about quality of who's caring for these breeches in these papers. And they found that some papers said there's not much difference between vaginal or cesarean, and other papers said that cesarean was safer. And since it's kind of like confirmation bias, since organized medicine at that point wanted the safer route, and they thought that C-sections are easier, as we talked about earlier, they make more money doing them, blah, blah, blah. A paper came out in 2000 and that sort of codified the idea that C-section was a better idea. Turned out within 2 years, they looked at that paper and they broke it down, and there's no way that paper should have ever made it through peer review. The peer review process is corrupt. If you try to get a paper that's through peer review that's counter the narrative, it's going to be very hard to do. Most journals are sponsored by who? Big Pharma. Most medical schools are sponsored by who? Big Pharma. So not that Big Pharma has anything to do with breech, C-section, that sort of thing, but I'm just saying that it's very hard to get a paper through. And to see a paper like the term breech trial, which is that one I'm talking about, get put through with all the flaws of that paper just shows you that this was something there was confirmation bias. They wanted this paper to get out. And the minute it came out, instead of being solely adopted, as many papers are, taking years to change the way practice, within 6 months, most hospitals in the world and almost all residency programs will stop teaching breech birth. And so breech birth then became something that was to be feared. It just changed literally within a generation. Went from my generation, where it was considered normal and we loved doing them, to the next generation, which was taught that they were dangerous and you have to do a C-section, and they freaked them out. And there are stories after stories, guys, that of women that come into labor and delivery with a completely dilated, surprise breech, the butt beginning to stick out, or maybe a leg sticking out, and the labor and delivery unit panicking. And what do? They push that baby back up inside. They close the woman's legs together. They take her to the operating room. Mm-hmm. They give her general anesthesia so she has no recollection of the birth of her child. They do an emergency C-section. The baby goes to the nursery. The dad isn't even allowed in because she has general anesthesia. If they had a knowledgeable person down there, and I don't know how any hospital who does labor and delivery can function without a knowledgeable breech practitioner there, because it is 4 to 5% of all term pregnancies. That baby could have been, it could have been delivered on its own, or if it needed help, could have been out in 10, 15 seconds.
What's the trick? What's the trick to a breech delivery?
Just learning the skills.
And is it turning the baby?
Not necessarily. No, babies will generally, depending on the position of the mom, it's best to have her upright, not on her back.
Okay.
But gravity and that thing will make the baby rotate the right way. And the beauty of a breech birth, and what I teach, is that breech births are great because they tell you if they're okay or not. Mm. You can just see them. Mm. They're partly hanging out. Do they have good tone? Do they have good color? What's the cord look like? Does it look robust, or does it start to look pale and flaccid? Is the baby kicking or moving, or is the baby hanging like wet spaghetti? Those sorts of things tell you. And if the baby is not rotating right, or any of those other signs are not reassuring, then you put your hands on the breech and you do the rotations to free the arms or whatever else is stuck up on the pubic bone, and then you do the maneuvers to get the head out. It's not complicated. I make it sound, it's exciting. Mm-hmm. It's dramatic. Yeah. But it's to be respected, but not feared. And the fact that my colleagues who run the residency programs are not teaching this anymore. Yeah,
our midwife was like, I can deliver a breech baby if I have to. She was more worried about
getting arrested.
The liability.
Yeah, getting arrested.
Yeah.
Right. Yeah, right. Because that would be considered what? You didn't transport to the hospital? Right. If something happened. So there's that.
And if the hospitals were doing breech deliveries, then women would have a choice.
Yeah.
Women are choosing home breech birth because they're not given a choice. And they know the downsides of C-section that you asked and we talked about a little bit ago.
The whole battle on this whole topic it really is summed up by what's not being respected and what's being feared. And if women had more knowledge and education, and hopefully more women will understand and hear this conversation and share it, because there is so much that is so, and this is assuming obviously by all considerations that we're having a normal pregnancy. Like we don't want to discount that.
Right.
But who's defining normal?
Right.
And that's what you're doing. Right. Exactly.
No.
And
I want to say very openly that everyone has a bias.
Sure.
I openly admit that I have a bias, but my bias came after 40 years of spending
be on the other side.
25 years in the hospital, 28 years in the hospital setting, and 12 in the home birth setting. I freely admit my bias. Most of my colleagues do not admit that they have a bias. They see things one way. And the hypocrisy is glaring, because I can give you another example. The World Health Organization, I don't know if I get away saying that in this room because most of us have very low opinion of the World Health Organization. I'm hoping most of your listeners do.
Yeah, I'm sure.
We have governments that say we need to follow whatever the World Health Organization says. You know how they say that all the time.
Look what they did to us during COVID.
Yeah, and they want us to sign this treaty, and that they can declare a pandemic, and then we all have to shut down, and we should listen to the World Health Organization, Tedros and all his buddies. All right. World Health Organization 40 years ago made a statement that said that the optimal C-section rate is around 10%, maybe 15%. They said C-section rates lower than 10%, there's higher morbidity. C-section rates higher than 10%, there's higher morbidity. The World Health Organization said that. How many OBs and OB training programs and hospitals are following the World Health Organization guideline that says that any C-section rate above 10 to 15% has negative efficacy? In other words, it causes more problems than it's worth. None, because there's no country in the world right now that has a C-section rate of 10%.
Oh, really?
None.
Oh, wow.
That I know of. There is, please write in and correct me.
Wow.
No, I mean, I have friends that live in South Africa. C-section rate in South Africa is bordering on 80%. I know that in Brazil, in the private sector, it's 90%. With no concern about what they're doing, as we talked earlier, what they're doing to those moms and babies downstream. 90% of women. In Armenia, it's 70%, and home birth is illegal. Home birth is illegal.
Wow.
So I don't know. What do they do if a woman has a precipitous birth?
Yeah,
what do they do with her at home? Do they arrest her?
You know, it's funny. Back when we were having babies, there was a safe statement, a true statement that most of the world was still having their babies at home. Now, of course, that is,
completely. It's flipped on its ear.
Yeah, it's flipped, right? So, I mean, but that was true when we were there. Most of the world was still having babies at home. Again, I don't.
It's before our lifetime. In the 1920s, about 90% of babies were born at home.
Wow, yeah.
And by 1950, 90% of babies born in the hospital. So in that 30-year period of time, the organized medical community, spurred by Rockefeller, who hired a guy named Flexner to write a report that promoted the pharmaceutical brand of medicine, that vilified naturopaths, chiropractors, midwives, that took over the medical schools, made them pharmaceutical based. That was all done purposely. Obviously, Rockefeller's Standard Oil, I think, petroleum-based products. That's where pharmaceuticals come from. This was all done that way. And they went on a public relations campaign to vilify anybody who was in the natural health industry. And they did a great job. Mm-hmm. And they sold it to women, and they sold it to families. And suddenly women, and we used to live, and we used to be born in the home, we used to die in the home. In our lifetimes, they've sterilized both.
Yeah, I know.
Most of my family, and most of any family, has never seen someone die. They've never sat with someone and watched them die. People, especially during COVID, they made them die alone in a nursing home, which is the cruelest thing that you can possibly think of. And most people have never seen a baby born. You know what it does to a husband and to children? Our kids were in the
room. They watched our other...
Yes.
Our kids
and they will never look at birth with the same fear. Even if they go to an obstetrician who tries to put fear on them, they're going to go, hey, my mom did that. Mm-hmm. They're going to know differently.
And when you show them later, which we just did the night before Labor Day, we had our boys watch that when Simon was being born. And they truly had, I actually videotaped their reaction to watching it. And it was really cool because they're in their 20s now.
Yeah, they're like.
And to see them, they truly had, I think they were in awe of me. They were probably shocked by their own behavior because they didn't respect what was happening at the time, and
they were in and out of the room.
They were running around with lightsabers.
Is it come yet?
I didn't make a fight.
They're not that, but they know that it wasn't that kind of like mom went off for a couple of days and comes home with a baby.
No, they had such respect for it. They had total respect. But the first two babies, I did not make a peep because no one was there, right? But my midwife and my husband. When Daniel and Isaac were in the room when Simon was being born, my midwife was like slapping my inner thigh to stop screaming because she said, "You're going to scare the baby." But my girlfriend had a tripod with a camera set up. She wanted to take pictures, and I was like, "Okay." And then Daniel and Isaac are running around with lightsabers. My dad was supposed to have them in the other room, and they were, on the edge of my bed. And so anyway, I never got in my zone. Is the point? The first two, I was in a zone. I did not make a peep for hours. Yeah. My husband would.
Well, that is disruptive that they're there running around like that. You're not. They shouldn't be doing that. But the idea that even if they be in the house downstairs when you're upstairs having the baby,
no, my dad failed,
and they can run upstairs. They can run upstairs and see that baby.
My dad failed.
And the other thing too, having Dan there.
Yep.
Right. I get very emotional about this because I've talked about it a lot lately. But a father or a partner, husband, who witnesses the strength of his woman giving birth to their child, who maybe even catches the baby, who supports her, is going to be a better father, a better husband, statistically speaking. Not all. Some are going to be jerks anyway. And more likely to stay in the marriage than a father who's emasculated by wait in this chair out here and we'll call you when we're ready, or standing in the room watching his wife sort of be abused in some ways by getting an exam when she didn't want it or having something done to her. And he's just sitting there and he doesn't know what to do or doesn't speak up. She looks at him for her safety. He's not helping. That interferes with that relationship in the future because she feels he let her down. And he's sitting there with that stupid boofy hat on, and that blue jumper that they make you wear.
Yeah, totally.
Listen, I after watching the first two, I was begging her for me to.
Yeah, he didn't want my midwife there. I was like,
because I was like, I can do this.
Oh, he could have. I'm not worried about.
I don't want to.
Ellen was there to support me, like emotionally, in a different way.
It was so natural. It was so easy. I mean, I'm telling you, I swear, if the baby was posterior, I'm like, I even know how to turn it now. I'm like, I can do this. Yeah, it's like
see one, do one, teach one. Right?
Exactly. Be careful, ladies, who you choose to marry.
Right. Yeah.
For many reasons.
But she was like, oh no, I'm using Ellen. Yeah. Okay. All right. Bummer.
But Ellen could easily. I mean, a lot of times we stepped aside and let the husband do it. And we're just standing right there.
Ellen watched the Frank Sinatra saga because he had died recently. So Ellen was checked out with Frank for hours until it was time to get busy, right? But when it was time to get busy, she was there, and that was comforting.
A good midwife knows, again, like with breech birth.
Right.
It's good to know when to intervene, and it's good to know when not to intervene.
Absolutely.
And the same thing goes on at home birth. In the hospital, you're constantly being interrupted. Because they've got protocol dictated procedures they have to do. They have to take your blood pressure every hour or two. Mm-hmm. Think about this for a second. You come into the hospital. So they take your blood pressure when you first get there in labor, and it's normal. What are the chances that your blood pressure is going to be abnormal anytime during labor without you having any sort of symptoms?
It's going to be. Count on it.
What?
It's going to change if you get monitored.
Well, no,
but it's not going to be abnormal. Why are you taking it?
My point is they have a policy that says we need to chart it every hour. We need to chart it every 2 hours. All right. But it's not going to change. If she doesn't suddenly get lightheaded, and she's not going to suddenly have a low blood pressure, and she's not going to suddenly get malignant hypertension.
Yeah.
Right. But they have to chart it because they have to chart it. Now, when they blow this cup up on your arm and you're in labor, that's an intervention. Walking in the room and asking you how you're doing is actually an intervention.
I think that's stressful.
These are things that I would never have known if it weren't for the coattails of the midwives that I fortunately encountered early in my career, as I mentioned earlier, who approached me and asked me to take their. That's one of those sliding door moments, Dan, because I would probably still be the physician that I was. I was always challenging. I had that inquisitive nature, but if I hadn't been exposed to midwifery, I'd probably still be practicing in a hospital. Mm-hmm. I'd have a 30% C-section rate. I'd still be inducing people. I'd still be doing unnecessary vaginal exams. I don't know that I would have been exposed to the thing. So I feel blessed. I never saw myself on a path where I'd end up sitting here talking about these sorts of things when I first came out of residency, because who knew? But I'm so indebted to the fact that I have a platform and I don't have any masters. Yeah, I'm still licensed in California and Utah. And could somebody come after my license? Yeah, fine. Come after me, take me. It doesn't
matter. So what
are
you doing now? What are you doing?
Teaching.
I'm mostly teaching. I do some online consulting.
Okay.
Because
women
from all over the world, they reach out to me.
A woman that needs things answered or wants your time, they can pay you to.
Right. And sometimes I do it. I have a sliding scale. If they don't have any money, I talk to people in like Africa all the time.
Wow.
I even will meet, like I'll talk to a midwife in Africa.
How are you marketing?
Information. Where can people find you?
Everything is Birthing Instincts.
Birthinginstincts.com.
So it's www.birthinginstincts.com. It's the Birthing Instincts podcast. It's at Birthing Instincts on Instagram.
Yeah, it does a podcast.
I haven't done I haven't done TikTok, or I don't do Twitter. I'm old. I don't have the bandwidth for doing all that stuff.
I have to pull back.
And then I teach my course. That's my thing.
And do you teach that online?
No, that is a hands-on 2-day seminar. I go around the world.
Who are you teaching?
Mostly midwives, unfortunately. We can't really break into the residency program thing. They're not the academics. Sad. There's an ego thing involved that they don't want us coming in. I could take a group of like 10 residents, give me 1 day with them, and I could teach them other ways of thinking, and I could teach them the skills that are required to do a breech delivery. If you gave me 2 days, I would teach them twin skills as well. And they could learn it. They wouldn't be experts in it, but they would know what to do if a woman came in with a breech baby and not be afraid of it. Yeah. Right.
All right, let's get to the other pitfalls, because there's many.
Okay.
Right. So go through them. Well, let's do it quickly. I mean, we have all the shots that are recommended, even vitamin K. I mean, all this stuff has been normalized. Women are going to battle all of these things. So think about in your mind, because you know the pitfalls from beginning to end. Let's just knock them off.
Okay. Well, I want to talk about the precautionary principle, which is basically something in medicine where it's first do no harm.
Yeah.
Okay. So if you don't know something is safe, you shouldn't be doing it. And you shouldn't assume nature is unsafe. If you're going to intervene in nature's design, you've got to be damn sure that the intervention is safe.
Because God knows best.
Giving vaccines to a pregnant woman is idiotic in this day and age. All right. There's no reason to do it.
Okay, that's pitfall number one.
And the stupidity of it is, if you, as a man, for whatever reason, want to get a tetanus shot, which is a whole lot of things now on the internet about how stupid that is. All right. But say you want to get a tetanus shot, how often are you going to get it? What's the recommendation for a tetanus shot?
Gosh, I don't even know anymore.
It's like every 10 years.
Okay.
Right?
Yeah. Or when you get
after
injured,
a bite.
if you get a tetanus.
And that, again, if you look at the things, that's really stupid. You don't get it from
totally
rusty. You don't get it from rusty nails.
Yeah.
But, and people can look that up, but you get it every 10 years. And now you can't get a tetanus shot by itself, by the way. You have to get diphtheria and pertussis with it.
Yep.
But you get it every 10 years. But if you're pregnant this year and your doctor gives you a DTaP shot, and say you're pregnant again next year,
you get another one?
He's going to give you another one.
Wow.
It's kind of like if you give a moose a muffin, he'll want just one more, he'll want some jam to go with it. I mean, they want to give you another one the next year. In what God's name are you doing that for? Oh, we're doing it to increase your antibodies so they cross the placenta and give the baby more immunity. Well, before we do that, let's ask how many babies whose mothers weren't vaccinated are dying of pertussis in the first 6 months of life. And you can't find that number anywhere, by the way. What you can find are the number of deaths in the United States under age 5. And it's about 300.
Wow.
So 300 children under age 5 die from pertussis. Now, there's about 4 million babies born every year, just under. So let's talk about in 5 years, you've got 20 million babies, a little bit under. 320 million, you do the math, it's like 0. And yet we're giving 20 million babies, pregnant women, the DTaP shot.
That's
so
insane.
Using that same logic and then giving the RSV shot, again, RSV shot's been known to cause increased risks of preterm labor and preeclampsia. But they give it anyway. That's why they don't give it at 28 weeks, because they give it at 34 weeks in case you have preterm labor. But it's never been tested in a randomized placebo-controlled trial in anyone, let alone pregnant women. But we're going to give it to pregnant women in violation of the precautionary principle. And the ACOG people who are supposedly the guardians of obstetrics, are recommending this. Full on, still now. All right. Then you talk about newborn babies. You mentioned vitamin K.
Hold on. RhoGAM.
Okay. RhoGAM. RhoGAM has value in a woman who is Rh negative. She can be A, B, or O. It doesn't matter. And the baby is Rh positive. And if your husband is Rh negative and you're Rh negative, you can't have an Rh positive baby. There's no reason to give RhoGAM.
Sometimes they don't even check that.
Sometimes they don't even check that. And they want to give you RhoGAM at 28 weeks first. Let's talk about that. Sarah Wickham has written a book on this, and people can look that up too. There has been no research on giving RhoGAM at 28 weeks. Does it do any benefit? Does it have any risk? But it is giving the antibodies to the Rh factor. Now, if a baby is Rh positive and you're giving RhoGAM to the mother, some of those are going to cross the baby. Is the baby going to have some hemolysis in utero? No one looks because no one cares. Because there's no money in not giving RhoGAM. You can't bill for not giving RhoGAM. You can bill for giving RhoGAM. So they just decided that it does have some benefit after birth to giving to a woman who's Rh negative, who has an Rh positive baby, who may very well have had some bleeding and exchanged some blood.
Yeah. So if they suspect, then they could give it.
Yes.
Okay.
And again, giving it universally is always what they do.
Yeah, but
the data isn't strong, but the data is certainly, there's evidence to doing it. The problem now is that, is RhoGAM safe to give?
Yeah, it has 166 micrograms of mercury.
Is it mercury?
Uh-huh.
Okay. I don't know. That I don't know, mercury. But I know that it's also made from pooled blood products. And who's donating?
No, man.
And then we have the spike protein issue.
I'm taking my chances.
Then we have the spike protein issue. And of course, they don't give you unspiked protein RhoGAM. They don't tell you it's from pooled blood products.
Right.
They tell you it's safe and effective. Right? That's what they tell you.
Mm-hmm.
But they extrapolated that, giving it, because it has some benefit postpartum, to giving it at 28 weeks. There's no benefit. There's no known benefit to giving it at 28 weeks. Because it might prevent one small occasional bleed where the baby's sensitized, but we don't know the damage it's doing. And since they've never studied it, and now they have that same issue that they have with other vaccines where they say, well, we can't study giving women RhoGAM and not giving women RhoGAM because it's unethical.
Yeah, same vaccine thing.
That same whole vaccine, that circuitous argument that makes no sense.
Yeah, can't do a double-blind placebo trial because it's unethical. Yeah, I mean, so I guess if I were the mom, then I would say, based on your theory, right, don't do anything that you don't know is safe. Well, the fact is they don't know it's safe. So I would say, oh, can I have the study done on that at 28? Because there aren't any. So they're going to say, no, but it's safe and effective. Well, I just want to know how you think it's safe.
And by the way, if you are Rh negative and after you give birth to an Rh positive baby, there is a test that they can do on your blood. It's not perfect, but it's called the Kleihauer-Betke test.
There you go.
And it determines whether or not there's fetal red cells in your blood. They draw blood on mom and they can do it and they can see it. Now, if there's no fetal red cells in mom, then maybe you could pass on the RhoGAM. If there's a significant number, then maybe you had a kind of a sneaky bleed going on between you and the baby, and maybe you should get the RhoGAM.
Yeah.
So don't rule out RhoGAM for everyone, but don't give it routinely to everyone.
That was a great answer. Okay, now we're at birth.
Okay.
Pitfalls.
So first thing, there's no reason to ever cut the cord. Cutting the cord is for expediency. And the American College of OBGYN has been very magnanimous, and again, I'm being sarcastic, in that they've said that the delayed cord clamping should be for 1 minute. Now, 1 minute is a made-up number, kind of like 42 weeks or age 35 or 6 feet apart for that matter. Mm-hmm. They're made-up numbers. And there's no reason to cut the cord at all, because as the baby transitions to air, it's getting oxygen and nutrients from its mom.
Yeah, so our midwife cut the cord, and I was like, why? Hold on, more luck, because I read the longer the better.
Yeah, not right away, but
yeah, right.
Still.
She let it go for a while.
The argument you'll hear about leaving it too long is a stupid argument that the baby will get too much blood and the baby will get jaundiced.
Okay.
All right. Well, first of all, that's something that's easily treatable. Second of all, it's not. Nature didn't design a baby to get jaundiced. No one rushes in to cut the umbilical cord of any other mammal. Now, a lot of them just sever when the babies come out, but no one rushes in to cut a cord of a tiger.
Yeah, that was a good lesson.
So you don't need to cut the cord. Now, on very rare occasions, if the cord is flaccid, there's no pulsations in the cord, and the baby needs full-on resuscitation and your hospital doesn't have bedside resuscitation ability and the only way they can resuscitate that baby is in the warmer across the room, then okay, cut the cord.
Mm-hmm.
But if a baby is struggling and there's still pulsation in the cord, the last thing you want to do is cut the cord.
Now, our midwife did say it's okay. She waited for it not to pulsate anymore. And then she cut the cord.
And that point, and sometimes, when there's not pulsating anymore and you have a very short cord and baby can't get up to mom's chest, at that point you can cut the cord. But ultimately, you should leave the cord alone. Wait till the placenta comes out spontaneously. Don't pull on the cord. Don't yank on the placenta. You don't have to automatically put Pitocin in her IV or give her a shot in her hip of Pitocin. Let the placenta come out when it's ready. There's no time limit on that. They'll say, well, you have 30 minutes.
That's like pitfall number 4, right? Is like, there's a lot. We're trying to get through them all. Okay, because, giving the Pitocin because they're...
Giving Pitocin automatically is you're giving artificial drug, which can interfere potentially with mom's own secretion of oxytocin, milk letdown, all kinds of things. And you're giving it in order to prevent hemorrhage. But the reason a lot of women hemorrhage is because everybody's yanking on the cord and pulling on the placenta and trying to speed things up and not letting nature do its course.
Yeah, interesting. Okay.
Mm-hmm.
Again, my colleagues have been doing this for so long that way that they don't know anything else. Plus, again, they need to move on to another task. Mm-hmm. Once that baby's out, they want to get that placenta out. They want to stitch if they have to. They want to write the orders, and they need to move on to the next. They go back to the office, go to the next labor room if they're a laborist, and take care of other things. So they're on a timetable, but labor isn't on a timetable, and either is postpartum. Okay. Women can hemorrhage, whether and that's something you should watch for, but they're more likely to hemorrhage when you intervene in the process. And when they've been on Pitocin for induction for hours, their uterus is more likely to be exhausted and hemorrhage. So you're going to see more hemorrhages. You're going to see more hemorrhages after epidurals. You are going to see more. Now, more predictable? No. But leave nature alone. Leave the woman alone. Leave the mother and baby alone. That's how nature designed it.
So we got to get through these because of the time here. So we have
vitamin K.
Yeah, we need the other pitfalls. Let's just fire them.
Okay,
well,
I think the other two big ones are vitamin K and hepatitis. So hepatitis I can do in one word.
Yeah.
Don't.
Yeah, exactly. I agree with that.
Yeah. How about erythromycin in the eyes?
Don't.
Okay.
Okay, don't.
Because unless the mother is positive for chlamydia or gonorrhea, then maybe.
Yep.
But certainly as a routine, absolutely not.
Right. And that is what they're doing routinely.
And
yes. And moms have been cultured for that.
Yep. Oh,
in
100%.
normal prenatal care.
Yep.
Probably too many times they've been cultured for that.
Yep.
All right. So vitamin K. So vitamin K is an interesting one. And again, my friend Sarah Wickham wrote a book on that as well. Vitamin K, you have to look at why the babies are born technically, by the terminology used by medicine, vitamin K deficient. But are they? Are they really deficient?
No.
Or if they don't have it,
no, God doesn't.
There's a reason.
God doesn't do things for no reason.
That's right.
So you've probably heard this before, but maybe babies are supposed to not, their blood isn't supposed to be kind of clotty and thick. It's supposed to be watery and thin so that it can reach all the different areas that are developing and bring stem cells to all those areas. And nature has designed a system. And if nature thought vitamin K was necessary, then nature would have found a way for vitamin K to cross the placenta or baby to manufacture vitamin K beforehand. So the reason that vitamin K is given is, again, because you can bill for it. That's the reason. Yeah. Because the incidence of this thing called late onset vitamin K deficiency bleeding is about 6 per 100,000, which is about 1 in 16,000. So the medical model always errs on, quote, the side of caution, which I find as a funny statement because erring on the side of caution means you're willing to make mistakes to be cautious. It's really, if you actually break down what err on the side of caution means. But they're willing to give 16,000 babies a shot, potentially prevent one case of vitamin K deficiency bleeding, which can be devastating and catastrophic, understandable. So if that's your baby, that's a problem. With no concern about what's happening to the 15,999 babies who didn't need it.
Right.
And that's 16,000 charges for injection and vitamin K that they can bill for. And no one's looking to try to figure out what's wrong with that 1 in 16,000.
Absolutely.
Why don't we figure out the root cause of the problem, and maybe we can predict which babies need vitamin K and which babies don't. But that would be antithetical to the design of the medical model, which is to maximize revenue. Because if only, say, 200 babies out of 16,000 were at risk for this problem, and you could figure out why they were at risk, maybe they've got a genetic issue or something else, then we'd only give that many shots. That would be smarter.
Right.
Because we're altering nature's design by giving vitamin K.
Yep. Of
Simple
course.
as that.
Yeah. So, and I was raised in the Jewish culture, and I was taught, circumcision is done on the 8th day of life. By that time, the baby's gut microbiome was already kicking in and making vitamin K. Now, what was the reason that God told the Jews to do this on the 8th day of life? Was God some alien who knew this? Who knew this? Or was there some innate wisdom?
He knew.
Whoever wrote this down, that by 8 days of life, babies are going to live, most likely. They're not going to suffer that neonatal death. And they're going to be able to tolerate this a whole lot better.
Yep.
Absolutely.
So
God knew.
Same thing with kosher laws and things like that. There was, there are diseases that came in split-hoofed animals, like pigs and deer and things like that, that they were told you not
like wash your hands before you eat. It's just a good common practice.
Is that in the Bible, by the way?
Yeah.
Semmelweis was a man who discovered that if you wash your hands between the anatomy lab and putting ungloved hands into a woman in labor, you could prevent puerperal sepsis, bring it almost down to zero. And for that, he was put in an insane asylum.
Mm-hmm.
Wow.
Right.
I do have a question. So if after all this communication and conversation about all the things women need to be aware of, and husbands as well, and they still opt to go to a hospital, or need to go to a hospital,
as certainly is a very reasonable choice,
right? How good is a birth plan to have? How I think it is important for a woman to go through that with her team of doctors or the obstetric people that are handling her pregnancy and childbirth. How much enforcement? I do believe that is up to the husband, that he should be relegated that task of staying on point with that throughout that entire labor and delivery.
Yeah, the partner, and first of all, this should be discussed well before you get toward the third trimester. This should be discussed very early on with your team. I even talked about it earlier, that even before you're pregnant, you want to feel out your OB group and how they're going to manage these sorts of things and how they feel about birth plans. But definitely have a birth plan. Remember that policies are not laws. Make sure that they, if you have somebody you trust that's caring for you, then it makes it a lot easier. If you're being cared for by a stranger because that happens to be the person that's on call that day, they are not invested in you, and all they want to do is get through their shift and make sure they don't have a bad outcome and then go home to their family, which is not unreasonable for them, but it isn't their ethical calling. Their Hippocratic oath is to take care of you. If you know that person is going to care about you, it makes it a lot easier. But if they're not, you need to stand up for what you want. And I even have guidelines that I talk about when I do my 2-day seminar about things that you can do if you feel like you're being bullied.
Oh, good.
Good. One of the things that you can do is, first of all, you could fire that caregiver. People don't know that. Mm-hmm. And they'll say, well, that's the only doctor that's on today. I'm sorry, you need to find me somebody else. And the hospital has an obligation.
You have power.
Hospital has an obligation.
That's good to know. Okay.
You don't want to do it. You don't want to make it. You don't want to make it into a conflict, but sometimes they do. And if you feel you're being coerced, or they say we want to take your baby to the nursery because we think your baby's breathing too fast, and you think, no, I want my baby skin to skin with me. I think the baby will come around just fine. And they start to give you this hard time. You can say, time out. I want to have an ethics consult, or I want to talk to the chaplain.
Wow.
Hospitals have in their mandates, whatever it's called, bylaws, that they have to honor that. So it may, even though the ethicist is paid for by the hospital, and that's a conflict, it may be a cooling down period where that doctor, that neonatologist who's badgering you, has to step out of the room, and they have to leave you.
Yeah, people don't know, parents don't know they have that power.
No, they don't.
So that's really good.
They don't have to sign any consent form.
Right. Well, by the way, this would take more time, but it's important, I think, for people to understand this informed consent topic. Biologics is something that's also entering into this conversation, which transcends just vaccines, but it does include vaccines. So if someone goes in for a routine surgery or something and they sign off for their own protection and what they want as their informed consent, the hospital, they are trying to get power over that right now. And so there are things that are scarily changing if people aren't aware and don't start talking and standing up against this stuff.
Right. And then, you know, speaking of that, they also, it's a slightly different topic, but the placenta is something that a lot of hospitals I've been reading about. And again, I didn't even know this but they've been selling them. They've been wanting to keep the placenta and you know, it's your placenta.
Yeah, we planted trees.
And if a hospital, if a hospital says, no, you can't take that, it's hazardous waste, just say, you know what, I'm taking my placenta.
Yeah.
The interesting whole thing about hazardous waste, by the way, if you cut yourself at home and have bloody bandages, where do you throw them?
Garbage. Trash can.
If you cut yourself in the hospital and have bloody bandages, where do they go?
Dispensary.
Hazardous
or
waste.
Yeah.
Right. You know, it's hundreds of dollars. We in our office, we used to have these red bins, and we have to put our hazardous waste. But if you're at home, you know, your tampon or whatever just goes in. It goes in. Yeah, it's great.
Oh gosh, that's a whole nother conversation.
Guys, I have to wrap it up. Honestly,
I know this is really.
We have another guest.
We could do a part 2 later.
Yeah, exactly. I think we probably should because I think.
Well, we didn't even get to twins. We didn't get to.
I know. There's a lot.
But we did talk about the important things to me, like the twin growth curve. People who have twins understand that.
Yeah.
The Friedman curve is a bunch of crap. The continuous fetal monitoring is something. Yes, have a birth plan, but work it out. You know. Do your homework. This is like the wedding thing. Plan ahead. Put efforts into them. Hire a doula.
Yes.
Find a doula you trust, who's independent, doesn't work for the hospital, who's there to give you advice and guide you. A lot of the times I consult with women around the world because their doulas told them about me. Not because their doctor told them about me, because of course the doctors.
So I hope people come and track you down.
Yeah, well, that's what I was going to say. So tell them where they find you. So there are people who might want to take a class, consult with you. Tell them where they
everything is on my website at birthinginstincts.com. If you wanted to find out where I'm going to be next, I have an events page and where I'm going to be teaching. And then if you want to host a 2-day conference in your community, we can help you with that. That's great. It doesn't matter what country you're in. I take these tours and I travel. And I really love my life right now. And part of I miss being at births, but I don't miss being on call, because being on call is very hard. And your midwives and your doulas and stuff and your birth photographers all deserve a huge amount of credit for giving up their life to do that sort of thing. And then my podcast is Birthing Instincts Podcast with my co-host Bliss Young. She's a traditional midwife, and we've been together now for 8 years doing the podcast, and we have interesting guests on. I saw you had Andy Schoonover on recently. We talked about crowd health, and that was really good. And then I haven't had Jenny McCarthy on yet, but we're probably going to try to get Dell on. And so again, we have very interesting things, and we talk about topics. Sometimes it's just me and Bliss. Sometimes we have guests, and then we have a Patreon group. By the way, I should mention this, that our Patreon group is behind a paywall, and it's a community. We have over 1,000 members, and there are different tiers where we offer things like peer review. We offer Q&A once a month. Bliss does a village prenatal where she'll do a prenatal visit with her and all these other moms, on virtually, and you get an idea of what it's like to be in midwifery care. So even if you are thinking about having a hospital birth with an obstetrician and maybe don't want to experience discomfort, and despite everything we said, you want to get an epidural, that's your choice as long as you know the pros and cons. But it wouldn't hurt you to get a couple of prenatal visits, pay out of pocket, hire a midwife, have her come to your home, do a couple prenatal visits at home, not to try to convince you anything else, but just to help you stay healthy.
There you go. All right. You're going to want to share this show, especially with your daughters, right? We want to change the mindset of this whole thing from beginning.
If we can catch them early,
then we
can
share
prevent
with your
the fear.
Yeah, absolutely. Dr. Stu, what a pleasure.
Dr. Dan, thank you.
Thank you
very much.
Great.
All right.
Thank you.
Thank you, guys.
Awesome.